The switching to alternative TKI in the treatment of chronic myeloid leukemia is always based on the obtention of milestones, so the early and later milestones that need to be achieved in any patient who starts therapy with a TKI. So the classical milestone that NCCN and ELN provide always the 3 months or the 6 months molecular or even cytogenetic response. And we now, as we discussed previously, that the lack of less than 10% of PCR by 3 months is a sign, in more or less, depending on the risk of the patient, maybe a red flag that really allow us to really follow patient more closely. In some cases, really introduce a switch of TKI early on. In other patients, maybe follow closely to see truly if they really achieve these milestones later on. However, the second important milestone, of course, is the 12 months. The 12 months, we know that most patients consistently need to be in a complete cytogenetic response, and in an ideal world, achieve major molecular response. We know that this is not really a criteria for NCCN, it's more for ELN, but definitely we know that at least the obtention of complete cytogenetic response at 1 year guarantee those patients who are going to do better later on. And obviously, the deeper molecular response the patient achieves at 1 year, the better outcome and the most likely or the more likely consideration for discontinuation of the drugs in the future. The main reason why we switch therapies on TKIs in patients with chronic myeloid leukemia is intolerance. Intolerance is a more common situation than resistance. We know that mainly with the second generation TKIs, it is really rare to release resistance in the first 3 months. However, we know that second generation TKIs may be, even first generation TKI may be associated with chronic or acute side effects that some patients may not really be able to continue because they are bothersome, or because they really have a pleural effusion, or because they may have any other condition that they will require switch of therapy. So by far, and for the last year, we have seen that the most common reason why we switch therapies are intolerance. It is true that because the plethora of drugs that we have in our practice, sometimes you see a practitioner who really switch very fast these drugs without trying to really intervene with supportive care and try to really keep the drug as long as we can. We always say that the degree of intolerance in patients with TKI is directly proportional to the amount of TKIs available outside the one that the patient is taking. So it's sometimes a tendency to really switch too early, and I think it's not really a good practice for our patients, because we need to really at least consider as much as we can to optimize the support of care, and of course, after failure of optimization of the support of this symptomatology, well, consideration of switching may be done.
In general, I think that switching of therapies is something that in the past we have had problems with, especially on patients and protocols, where we have seen that unfortunately often the therapies are switched very early. So we're very happy that there are multiple tyrosine kinase inhibitors, 5 of them at this time, that are available, and potentially more that are in trials. But one of the negative consequences of this has been that there has been a kind of a comfort level in switching early because there are so many drugs approved. And in general, that has been something that a lot of the CML experts have been pushing back on. We don't want to have the patients switching therapy early. So in general, what we have recommended is that there are standardized guidelines by the SOCAL as well as by the NCCN that say that in general, you monitor the PCR for BCR-ABL every 3 months in the first year, then every 3 to 6 months for the next 2 years, and then you can drop it to every 6 months to a year. And if you start seeing a rise in the PCR for BCR-ABL, confirm that the patient is compliant, and then you have to do a repeat PCR for BCR-ABL in 4 weeks. If the repeat PCR for BCR-ABL continues to show a 1 log or more increase, then that would be an appropriate indication to switch either from a first generation TKI to a second, or from one of the second generation to another second generation TKI or third generation. That is probably the most common scenario where one could switch, but what we don't want is that the switch happens after only one reading without any confirmation, or if there's an increase, for example, from 0.21 to 0.28 or so, we don't consider that very significant. That's not a 1 log increase, so that's not usually a scenario where we would make the switch. The second scenario where we think it's obviously very important to make a switch in therapy is in somebody's having a full-blown refractoriness or relapse that's morphologically apparent. So either their white count is going up, they're having a spleen enlargement, they're having worsening cytopenias, they're having increased blasts in the peripheral blood or bone marrow. In that situation, definitely one would be switching, but those are actually the patients that are ideal for clinical trials, and those are the patients we would strongly recommend at least consulting or discussing with your local hematology, oncology, or leukemia experts, because there are now a number of trials that are combining tyrosine kinase inhibitors with other active standard therapies such as hypomethylators or high-dose chemo, and also with other novel therapies such as immune agents, JAK inhibitors, BCL2 inhibitors, and such patients would have very poor outcomes by just switching from one tyrosine kinase inhibitor to other, and there's hope that by combining approaches we may be able to improve these outcomes. So I would really recommend to consider those patients for clinical trials.